Okay, thank you very much. So I'll speak to you now about the surgical management of neurotrophic keratopathy. These are my disclosures. So as Professor Dua has said, according to the classification of neurotrophic keratopathy, it's either mild, moderate, and severe, and the only common thing between the three is reduced corneal sensation. So it's essential that you test corneal sensation for every patient that presents with an ulcer before you put your anesthetic. So when do we actually resort to surgery in these patients? In mild NK, when you have persistent superficial punctate keratitis extensive like in these cases, you can start by doing just punctal cautery because it is much more superior than plugs. And remember not to do plugs or cautery until you have completely controlled the inflammation, because you don't want the pro-inflammatory mediators in the tears to make the ulcer worse. And then the next stage would be surgery to correct any anatomical malposition. So any entropion, ectropion needs to be corrected. Remember the blink leg of thalamus. That is a sign very commonly missed in patients with have inferior neurotrophic keratopathy, where the patient half blinks, doesn't blink completely. And in these cases, you can do lower lid retractor recession, and that will help, especially with thyroid eye diseases. Or you can do medial canthotomy to start, and followed by lateral canthoplasty in leg of thalamus. You can also use gold weights, and the problem with gold weights is that if you don't tailor them properly, they can cause a lot of astigmatism. So you really need to try them out. There are different trial sets which you try them to make sure that you're getting in the right gold weight to put in your upper lid. If there is any mild conjunctivochalasis, it will not make the lids, make the tear film even. So very important to excise any conjunctivochalasis. And remember, when you excise conjunctivochalasis, the patient needs to be looking up so you don't excise too much conjunctiva. So now the next stage would be surgery to heal any persistent epithelial defect, and with or without melting. So stages moderate to severe neurotrophic keratopathy. So these are the different therapeutic approaches which we will discuss briefly in the next slide. So the first therapeutic and easier therapeutic approach is to use Botox or Dysport. Remember, the dose of the Botox and Dysport are different because the Botox has 100 units per mil, while the Dysport has 300 units per mil. So you need to get 15 to 30 units whichever way from the Botox or Dysport, and it acts by blocking new muscular transmission at the motor end plate. So that's how, and it usually starts to work in 2 to 7 days. In 1 week, it gets the maximum effect. We usually like to inject it along the upper border of tarsus this way, and we found that the complication rates, such as double vision diplopia, is much less with injecting it on just along the upper border of tarsus this way. The advantage is you can close the lids while you can still examine the patients. It reduces pain because of less exposure of the nerves, reduces inflammation, reducing the tear evaporation, and reduces the rubbing of the lid along the ocular surface. And this is an example of a herpetic patient with post-neurotrophic ulcer, and you can see the rolled edge of the ulcer. We give the patient Botox, and in 1 week, it was half the size. In 2 weeks, it was completely healed. And however, there are complications to Botox. We have seen superior rectus undercorrection in 30%, but in the literature it can be much more than that. Reduced Bell's phenomena, persistent diplopia, and persistent ptosis, like in this patient, which required surgery for the ptosis because the doctor didn't wait until 1 week and he re-injected. So remember, the lids doesn't fall off necessarily immediately. You will need to wait up to a week for the lid to fall. And if you don't see it falling after 1 or 2 days, don't go and re-inject again. Wait for a week before you think of doing any further intervention. The gold standard for neurotrophic keratopathy is tarsorrhaphy. So if nothing works, tarsorrhaphy will work. So you can do a gray line split, de-epithelialize the posterior lamella, and suture. And we like to always suture over a bolster so that it does not macerate the lids. This is a patient post-stem cell transplant with a non-healing epithelial defect. We put a tarsorrhaphy and it completely healed. Now, amniotic membrane can be used, like in this patient, with I hope the video works. So this patient had chemical burn, had completely neurotrophic ulcerated surface, and we used Omnigen 500, which is a product off the shelf that is vacuum dehydrated. And you can see here we use two hooks, and we hook the Omnigen under the lids with the two hooks. And you can put some drops after you've put the amnion, because if you put the drops first, the amnion will crumble, and then you measure and you can put a conformer, the right sides, to maintain the phonesis. Very useful technique in Steven Johnson's, in acute chemical burns, where patients have neurotrophic ulcers. Again, you can use the amniotic membrane in multi-layer techniques. This is a patient who had an infective ulcer. The infection healed, but he remained with a neurotrophic ulcer, and you can see here. And we put a multi-layer amniotic membrane transplanted here, and we put multiple layers, and we suture only the top layer, and you can see it gets completely incorporated, and the stoma starts to build on top of it, and then epithelialization happen. And this is within 6 months, it's completely integrated. And we've published that when you have breaks in the Bowman's membrane, the keratocytes actually repopulate your amnion and starts to lay down collagen, and the epithelium popularizes on top of it. So very useful technique in neurotrophic ulcers. Now remember that with amniotic membrane, you can get failures, you can get infections, you can get transmission of disease. Whenever we put an amniotic membrane, we like to put a bandage contact lens, but be wary of persistent infection. The infection can get worse if it's an infected ulcer, or you can do a tarsophy to maintain the amnion in place so it doesn't fall off. Another very useful technique is the conch pedicle flaps, and we use this for neurotrophic ulcer. Once the infection is healed, you sometimes end up with an epithelial defect. And the advantage of the pedicle flap is that you don't have to remove all the epithelium. You just remove the epithelium in the area where there is the ulcer. And the rest of pedicle can go on normal epithelium. And this is another example where we do another technique, which is the free conjunctival graft. So if there is no healthy conjunctiva to take, like in this patient with chemical burn, you can take actually conjunctiva from the other side and then suture it to areas of remaining conjunctiva, and you can see it completely gets taken up. And you can actually use this conjunctiva later on in a later stage to reform the fornix in this patient. This was done together with limbal stem cell transplantation, and the patient had eventually 6/9 vision. So very useful technique to use the conjunctiva from the other side. This is a patient with chemical burn with a neurotrophic ulcer where nothing worked. Tarsophy didn't work. You know, we did a tarsophy, then another ulcer came, then a third ulcer came. So what we did is a limbal to limbus lamellar corneal transplantation, and you can see it healed very nicely. And this is the superior lamella that we glued with fibrin glue on top, and just sutures at the periphery, and has completely taken, and you can see that it's cleared, and you can see that the patient had cataract. And this is how we maintained his epithelial defect. You can also do, if you have a neurotrophic keratitis which has led to perforation, you can do a small therapeutic keratoplasty, where later on you can make a visual keratoplasty. Don't forget about stem cell transplantation. If you have limbal stem cell transplantation and there is no epithelium to restore the ocular surface, then you might want to go for autolimbal or allolimbal transplantation. Now, the direct neurotization is the only technique that is there to actually treat the problem with neurotrophic keratopathy, where you take a sural nerve and use it to connect the supratrochlear and supraorbital nerve from the other side to the eye with the neurotrophic ulcers, and then you make little twigs from the nerves and you put them in little pockets, which you can do with your crescent braid around the cornea, and that will restore innervation. And usually we see that the sensation returns before the actual innervation, and you can see with confocal microscopy that eventually the innervation comes back. A very elaborate procedure, but this is actually the actual treatment for neurotrophic keratopathy. Don't forget that you need to continue with your medical management, use lubricants to protect the ocular surface, also control the inflammation, and use epithelium promoters such as lacrimera or calcicols. So the take-home message, surgical intervention in the early stage. You can do punctal cautery, you can correct the malpositions, any conjunctival chalazies you have to remove. Think of gold weight or lower lid retractor recessions if you have blink lag ophthalmos. And later diseases, later stages 2 or 3, you do your Botox or Tarsafi if Botox doesn't work, and you may want to use amniotic membrane or hooding in the more advanced stages. If there is no stem cell, you can go for stem cell transplantation, and the final is the direct neurotization. Thank you.
So we're happy to share experience if anybody wants to make a comment or has any questions. There's one thing which didn't come out in the discussion so far, is that when you have a problem with the cornea, especially pain without stain, and the patient got a lot of symptoms, but you can't find any physical cause for it, put a drop of anesthetic in the patient's eye, one eye at a time, and see if the pain goes away. If the pain goes away, then you know it is surface pain and you can treat it. And we have even used very judiciously, with due caution, topical anesthesia as a treatment to break the pain cycle, and it works. But if you put an anesthetic drop and the patient's pain does not go away, that means it's more central pain, or a peripheral pain is now embedded centrally, and they need pain suppressing tablets, and you have to refer to the pain clinic, amitriptyline or Tegretol or something like that, because their pain is more central pain. The other thing to bear in mind is that, like I said, test the conjunctival sensation and the corneal sensation. If the corneal sensations are absent but conjunctival sensations are present, then you know there are nerves in the perilimbal area. Therefore, treatment with nerve growth factor drops, etc., can help those to regenerate into the cornea. But if there is no surface sensation at all, then putting drops will not let new nerves to grow in, because there are no new nerves. So if your trigeminal nerve is transected, or there's an acoustic neuroma in surgery, you've lost the trigeminal nerve, there will be complete loss of sensation, and only treatment there will be, you will have to do direct neurotization from the other eye. There the local drops will not have a long-term effect. So important to distinguish between corneal conjunctival sensation and the other points that we mentioned, whether they respond to anesthesia or not. Any question here?
When we start treating the microbial keratitis, and after sometimes we have a situation that we don't know that it's the infection which is leading to the epithelial defect, or as you said that every infection can affect the nerves and lead to NK. So how do we kind of go about that?
So if you have, and that's very common, and following corneal ulcers, you end up with non-healing epithelial defect. So you think that the infection is gone, but the defect is still there, and that happens quite commonly. So obviously you will check corneal sensations, and you test them on the ulcer and around, and you will see a difference. So you have to establish whether the sensations have been lost or not. Once you know what you're dealing with, you will have lots of signs to tell you that the infection has been treated. So the hypopion will go, the AC cells will be less, the circumcorneal injection becomes less, the vascularization starts to become less active, the corneal edema settles, the KP start to go if there was some. So all these signs will tell you, and also importantly, the edema outside the area of the ulcer is quite edematous all around. That will also regress. So you know you have treated the infection. And if it is still not healing and you've got a persistent defect and the sensations are low, then you start with all these things. And you will go first with the medical line of treatment, and if that doesn't work, you will try a bandage lens, a punctal plug. When you put a bandage lens in an eye, the risk of infection goes up 11 times. And it is even more if you put a bandage lens in an eye with an epithelial defect. So especially if the patient sleeps with the lens in. So you have to give prophylactic antibiotic, you have to use preservative-free drops and get it to heal. So you go in the step ladder, medical treatment, that doesn't work. Some interventions like Botox or punctal, Quattri or bandage lens. And if that doesn't work, then you go into, tarsorrhaphy usually often always works. So that's how we would approach this. But one thing which we tend to forget, that if you are treating your infection with aminoglycosides like tobramycin, gentamicin, amikacin, they are extremely toxic. And you get huge ulcers of the conjunctiva, both above and below, but usually below. And you will get a non-healing defect because of the toxicity. And also prolonged use of antivirals is very epithelial toxic, and there's already reduced sensation and the epithelium won't heal. So you have to stop those and see the response. And there's a little sign we published, the up-down sign. So you ask the patient to look up, the lower part of the conjunctiva will be extremely congested and red. You ask the patient to look down, the upper part is white. Then you know this is toxicity. It is not infection or persistence of the infection, and it's not allergy, because allergy will be all over. So that's a very good sign of toxicity.
Thank you, sir.
Aminoglycosides and quinolines are cardiotoxic. Which is a safer antibiotic you can advise to use?
No, you have to use them, but you have to titrate according to the response, and don't use them for a very long time. So we will start, like for example, every half an hour alternating aminoglycoside and a cephalosporin. This is in a site-threatening ulcer. So the first 24 hours we are giving them 1 hourly each drop, day and night. So we say that neither the patient nor the nurse gets any sleep. So intensive loading dose. And after that you have to cut it down. If there's a response, you can straight away cut it down to 6 times a day, and as it heals down to 4 times a day, and then stop. So you never taper the antibiotics below 4 times a day, because you go to the sub inhibitory concentration, you get resistance. But if you can get a good effect with the fluoroquinolones, they are less toxic, and the cephalosporins are less toxic than the aminoglycosides. So like your cefiroxim and ceftazidime and so forth. Okay.
Excuse me.
Sorry, what? We'll just take one. Yeah, we started 5 minutes late, but we are just on time. We will take one more question.
Sir, I'm dealing with a patient. 3 months.
Sorry, start again. Yeah, go on.
I'm dealing a patient of NK. 3 months before I have done cataract surgery, and after 3 months, the herpes simplex keratitis has developed. Both endothelium is also involved, stroma is also involved, and epithelium is also involved. I gave him 2 times Predfort and all antivirals, Vitsan gel 5 times and all this. And till that 2 months is over, but there is persistent epithelial defect is there.
Yeah.
I stopped all Vitsan gel and all. There I put on lubricating gels, and but still it is not healing.
Yeah. So what you have to do, and this is increasingly being observed, you get these non-healing epithelial defects following cataract surgery. The first thing is that in the workup, make sure the patient doesn't have borderline dry eye. It's very important to make sure there is no, if there is dry eye, you have to treat that before and then take a lot of lubrication after the surgery and warn the patient that there's going to be a problem. But you have ended up with a problem. It may not be dry eye related, it can happen without dry eye. And if you're using non-steroidal anti-inflammatory drugs, then avoid those, because they will cause rapid melting. And yeah, I'm just saying if as a point of note. But in your case now, you have to use do a tarsorrhaphy. Tell the patient it's going to affect your site. We're going to do a central tarsorrhaphy, a central ulcer. Let it heal. Put your drops from the side, and if it looks right and left, you can see the lesion and see if it's healing. And once it's healed, then you can open the tarsorrhaphy. So it's like a temporary but an openable tarsorrhaphy. You just freshen the edges, stitch it, and then you can just snip it off.
And I wouldn't use steroids. You need to stop the steroids to allow the ulcer to heal. Yeah.
Yeah. Yeah, I think that too. Steroids promote melting and promote non-healing. So you can use, if you want an anti-inflammatory, if you have cyclosporin drops, those would be probably safer. Thank you very much for coming, and I wish you a good Congress. Yes.